Good afternoon, everybody. Thank you so much for joining us today for our webinar on COVID-19 transplant in children, presented jointly by BC Transplant and the Transplant Research Foundation of BC. I'm Tina Robinson. I'm the Manager of Communications with BC Transplant. Before we get started, I'm just going to go over a few items so you know how to participate in today's event. Just going to move the slide forward. Yeah. So you've joined the presentation by default with your audio and video muted. We've turned off the chat function just to make it easier for us to monitor the questions panel. The webinar is being recorded and it will be made online afterwards through BC Transplant and Transplant Research Foundation. For those of you joining on your computer, you can submit text questions to the presenters by typing them into the questions pane found in the Zoom toolbar at the bottom of the meeting window. Everybody is going to be able to see the questions that you ask, and you can also upvote questions that you'd like to see answered by clicking the thumbs up under the question, sort of somewhat like a Facebook like. As a question receives more thumbs up, it'll go up higher in the questions pane, and that helps us prioritize the questions that we receive through the course of the session. I would ask that you please hold on asking your questions until after all the panelists have spoken, as it's possible that your question will be asked by a later panelist. And also, in order to protect your privacy, when you ask a question, don't provide any personal identifying information. You can also ask questions anonymously. And so we'll get started by first introducing you to the moderator for the webinar, Christy Caldwell, who's the Senior Advisor for Transplant Research Advocacy at the Transplant Research of BC. Take it away, Christy.
Thanks, Tina, and hello everyone joining us today. BC Transplant and the Transplant Research Foundation of BC are pleased to partner to bring you today's webinar on COVID-19, transplant, and children. We are excited to have 3 panelists joining us, each of whom will speak to an aspect of today's webinar. And I believe, oh, sorry, almost forgot the introductions. So we have Dr. Tom Blight-Hansen, who is the Director of the Multi-Organ Transplant Program at BC Children's Hospital. And we have Dr. Hannah Mijovic, who is a pediatric infectious disease specialist at BC Children's Hospital. And of course, last but not least, we have Dr. Jag Gill, who is the Medical Director for the Renal Transplant Program at St. Paul's Hospital or Providence Healthcare. And I believe that we're actually going to be starting today with Dr. Mijovic. Sorry, Hannah, I knew I was going to say your name wrong. So Hannah, you will start us off.
Sounds good. Hi, everyone. Thank you for joining. My first name is Hannah, if that makes it easier. And I had a couple of slides about what we know about COVID in children in general, and then a couple of slides about vaccines. So I'll try to address some of the questions that you sent in, but certainly happy to delve into more detail later. So to start off, how common is COVID-19 in children? This picture here is for British Columbia, and in BC, about 9% of all the people tested were in children, so a lot less than the general population. And what that means in terms of numbers is 471 children as of this past Friday were confirmed to have COVID, and only 5 of these children were hospitalized. So a much lower rate of hospitalizations compared to what we see in adults. And that's roughly reflected in what we've been seeing across Canada as well. So among people who are tested, COVID certainly does occur in children, but is not as common. And the rates of hospitalizations and ICU admissions are fortunately lower than what we see among adults. Next slide. So what happens when children get COVID? Oftentimes probably nothing. They're asymptomatic. If we don't test, we won't know that they have COVID. If they do get infection, it is in most cases mild to moderate infection, presenting similarly to adults with fever, cough, and sore throat. Rarely, children, just like adults, can get severe pneumonia and may require mechanical ventilation. What we have also observed with pediatric COVID is that children might come in sick with another illness. We might find another virus or another bacteria that could be contributing, and it's not completely clear how much COVID that we find when we did the extensive testing is part of that illness. Next slide. where I just thought I would spend a moment talking about multisystem inflammatory syndrome associated with COVID, because it's gotten quite some attention in the media. So that's more specific to children. It does represent an exaggerated inflammatory reaction resulting in severe illness that usually starts with fever, but can involve skin, can involve lungs. Some children can get a lot of inflammation in the eyes, abdominal pain, and depending on the degree of inflammation, they can have problems with different organs. And that's quite distinct from COVID infection itself. It's actually something that happens after the infection has already occurred. And while this is a very severe illness, usually children have complete recovery. Again, this is rare. It's been seen in less than 1% in children with COVID overall. And although we've had some suspected cases in BC, none of these children actually tested positive for COVID, either on initial test or by antibody. So we haven't had any confirmed cases. And what we think that happened with these children who were investigated is that they were sick because of another cause. So not only COVID, but also other infections can give you severe inflammatory response. Next slide, please. Why is COVID generally milder in children? We don't know. So unlike some other viruses, such as flu, children in general don't get as sick from COVID. Is it because they have different immune response than adults? Possibly. Some people speculate that COVID is in competition with other common childhood viruses and might get suppressed, possibly. Some of you were wondering about the role of ACE enzyme, because that's implicated in COVID infection and ACE receptors. The bottom line is that that blood pressure medication, specifically ACE inhibitors, that some people are taking, do not increase a chance of getting COVID-19. They may in fact be protective, and we're not completely clear on how differences in ACE enzyme between children and adults would protect children from getting COVID. Next slide. Are children less likely to spread COVID? So yes, based on what we know so far. So, and obviously a lot of that has to be taken in the context of how much COVID there is in the community to begin with. So from what we know so far, looking at studies among households of children who were infected, and they were able to trace the source of infection back, the children in most cases got COVID infection from adults rather than children being the initial case and passing it to adults. And then based on what we've seen in several countries where schools actually remained open, albeit with some modifications during the first wave of infection, for the purpose of thinking of BC, it's probably helpful to look at countries like Australia and Sweden, where the rates of community transmission were relatively low. With these schools, again, child-to-child or child-to-adult transmission was rare. Again, what was helpful with these schools was having effective contact tracing, meaning that children were unlikely to attend school when they were sick, and that appropriate self-isolation measures were put in place very quickly. Next slide. And just a couple of points about the vaccine. When will we have a vaccine? This is on a daily tracker based on World Health Organization data that gets posted on the Guardian website. But perhaps to emphasize that we have an unprecedented numbers of vaccines that are being investigated, unlike how vaccines are usually developed for other illnesses. So a large number of these vaccines, 142, have not yet been started in human trials. So they're the lab vaccines for now. And then we have a smattering of vaccines that are tested in adults, in healthy adults. And out of these, only 9, so that's the phase 3, are being tested in large-scale efficacy trials. So what that means is that based on smaller level studies, we believe that these vaccines are safe in healthy adults, but we now need larger scale data to actually show us how efficacious they are. So does giving these vaccines actually provide us with enough protection to be able to say that a vaccine will be able to protect us from COVID? And finally, none of the vaccines are approved yet. So perhaps being a bit optimistic, we are hopeful that we might have a vaccine approved late at the end of this year or early in 2021. And next slide. When will we have COVID vaccine for transplant recipients? Great question. Likely not in the immediate future. So the first thing that will happen after we've been able to establish some safety and efficacy in healthy adults, depending on what the vaccine is, we would then be able to prioritize children and teenagers, immunocompromised adults, and pregnant women for further studies. Next slide. Will the COVID vaccine be safe and effective for transplant recipients? So first of all, it depends on the type of the vaccine. Based on experience with other vaccines so far, non-live vaccines generally are considered safe post-transplant. We obviously do not know how that will look like for a COVID vaccine because none of the vaccines have been approved, and it will be helpful to have more information about the specific profile of the vaccine in order to be able to ask questions around safety, specifically in transplant recipients. We know that vaccine efficacy is generally reduced post-transplant, meaning that protection from vaccine may not be sufficient in transplant recipients, and the transplant recipients, if the vaccine is safe, may need more doses. And in terms of what will probably be done on a more immediate basis is optimizing indirect protection, meaning that we may prioritize healthy adults who are contacts of people with a transplant for vaccination. So for example, if you have a child who's had a transplant, most likely parents and other household members will be prioritized for vaccination. Next slide. What else can I do to protect myself, my child from COVID? And Tom and Jag will talk further to that, but depending on the degree of immune suppression, you will get individualized advice from your healthcare provider. Routine recommendations still hold. Frequent hand washing, especially if you have a young child who 20 seconds probably feels like an eternity, going over how long it takes and how to wash all parts of hands. Using alcohol-based sanitizers, physical distancing when possible, masks generally recommended in children over 10, and then in younger children if they can wear them, if they're older than 10, can wear them properly, and that means really not touching their face a lot, because kind of touching your face defeats the purpose of the transplant. I mean, my time is up, so the only last thing I will emphasize, we do have vaccines that are recommended in transplant, post-transplant, that are efficacious, and that's the flu vaccine, staying up to date on other recommended vaccines. Last slide. And just making a pitch for our family immunization clinic. We do have some drop-in spots available for children, but it is helpful if you book in advance. Thank you.
All right, thanks, Hannah. And again, I'd like to thank all of the 91 participants so far who are attending this webinar for joining us. I'm going to keep my comments actually fairly brief. I'd like to leave some room for questions, as I'm sure there are going to be several of them. Next slide, please. I will just start by just adding a little bit maybe to what Hannah was saying before in terms of what we know about COVID-19 infection in children who have had transplants. When we first discussed our recommendations in June and early July, one of the overriding features was that we really didn't have very much information about cases where children with transplants had been infected with COVID-19. We have had several meetings with, in fact, all of the specialists at Children's Hospital here who take care of children who have immunocompromising conditions, so that includes transplants, but other diseases where the immune system is affected. and we made initially a very strong recommendation to keep children generally isolated and protected from any risk of infection. And this was based on concerns that we have about other viruses, for example, influenza, which we know can be particularly severe in children and who we expected might be at a much higher risk related to COVID-19. That, in fact, hasn't actually been borne out, and as you saw from the previous presentation, it seems that children actually, relatively speaking, are much more protected from COVID-19 relative to adults, and to, in particular, adults who have other health conditions. The speed with which we were able to proceed to a recommendation was affected by the absence of reports of COVID-19 infection in transplant patients. And so it's sometimes hard to make a statement about something that we're not seeing. But now, several months in, 4 or 5 months into this epidemic, it really is the case that we have not seen in the world many cases of COVID-19 infection in children who've been transplanted, and in particular, very few episodes of children with severe infection. This slide here is looking at all immunocompromised children, and we can see that a very small, of those who have actually been diagnosed with infection, which is probably an overrepresentation, it's probably missing children who have asymptomatic infection. A very small number of them have needed intensive care, and indeed most of them are able to avoid hospitalization entirely. Next slide. This is a breakdown from this data is taken from a registry which is based in the United States and is the largest compilation of cases that have been identified with COVID-19 that I can see. This again reiterates that of children who have been identified with COVID-19 infection, a very small minority need any kind of respiratory support at all in the form of oxygen, and most of these children are able to convalesce at home and not necessarily require even hospitalization. Next slide. So as you may have seen, we've done a lot of work with other specialists at the hospital to keep the recommendations up to date on the website for the BC Centre for Diseases Control. And so this information that I'm presenting you here is on that website, and you should know that it has all been reviewed by the specialists here at the BC Children's Hospital, and is updated as frequently as is feasible, especially as some of these recommendations change. And so based on the level of risk, we've really walked back our recommendation for keeping all children out of contact, and rather to really identify in particular children who might be at very high risk of getting sick with infection. And I'll have to add that even though we would identify a small number of children at high risk, this is still a very conservative recommendation in the sense that we don't actually know whether children who we would consider at very high risk based on the level of immunosuppression actually do represent a population at high risk, but we just don't have the confidence yet to say that that children in this situation might be similar. And so high risk really includes children who, for example, just had their transplant and are in the immediate period after induction immunosuppression. It includes similar situations such as children who are receiving induction chemotherapy for treatment of cancers, or treatment with high doses of steroid medication, for example, for treatment of rejection. These are children that we would be considering as potentially having a different risk from the general population, whereas those children who are on stable or maintenance types of immunosuppression or lower levels of immunosuppression risk, really we can't identify any kind of increased risk in these kids compared to the otherwise healthy child population. Next slide. We are getting a lot of questions about what to do with schools, and recognizing that even parents of children who don't have other health conditions, there is a lot of concern amongst parents about returning their children to school, and the safety measures that are put in place And although there is a tremendous amount of work being done both at the ministry level and I'm sure at your individual schools, communicating how these preventative measures have been put into place and what exactly is going to happen in the school setting is a source of anxiety for everybody. And these measures are meant to protect all children, and the recommendations we make to our parents and children in the clinic is to make sure that all children are adhering to the guidelines that would see us preventing each other from getting infected, including some of the measures that Dr. Mijovic was mentioning before. This guidance here is also found on the BC CDC website and is the paradigm that the schools are using from the most effective to the least effective health interventions that can be used in the school. But at a very high level, they really do mean keeping surfaces clean and keeping people away from other people at a physical distance, and when that's not possible, to use barriers between those people, which includes masks, which don't protect the person who's wearing the mask so much as it protects other people if you should happen to be infected and not have any symptoms of infection. Last slide. So that's all that I was going to mention at this point, but I'll pass it over to Dr. Gill to finish off this part of the presentation.
Thanks, Tom. Maybe I can go to the first slide. I can just give an overview. So really, I think my perspective here is to give some sort of sense to what the adult situation looks like, where unfortunately we have seen obviously more of an impact of COVID-19. And so, rather than kind of go through everything, I think just some highlights and some points to facilitate some discussion would be relevant. So firstly, I think, some key considerations that I've got listed up here on the slide is that as Dr. Blight-Hansen showed you, a lot of the data we're dealing with is very preliminary. The Canadian data in particular is very preliminary because thankfully there hasn't been the same number of cases as there have been in other parts of the world, and therefore it takes longer to accumulate some data to see exactly what the outcomes look like. So most of what we're gleaning from COVID-19 is either anecdotal based on just experiences we've had with patients, or it's from data that's been accumulated in other parts of the world where there's been a higher incidence of COVID in the general population. What does appear to be clear, and this is what we had presumed from the get-go, is that if you are a transplant recipient or an immunosuppressed individual, you are at higher risk of A, getting and acquiring COVID-19, and B, of developing complications, including an increased risk of hospitalization and an increased risk of death as a result of that. Now, the precise numbers around that are a bit murky, but the numbers, the data that's come out from places such as New York and from Spain, and some of this is preliminary still, but it does appear that there's up to a 50% higher incidence of acquiring COVID-19 among transplant recipients. And also from a complication perspective, hospitalization rates seem to be much higher. And in terms of the death proportion of people that are unfortunately suffering from death as a result of the disease, that number appears to be anywhere between 20 to 30% is what is being preliminarily reported among transplant patients. If you compare that to the general population, the rates have obviously varied around the world depending on how many cases they're actually reporting, how many cases they're testing, but it generally hovers somewhere between 2 to 15%. And the older the population is, the older the subpopulation you're looking at, the higher those risks are, kind of in the 15 to 20% range. So the 30% may not be exact, the 50% increased risk of developing it may not be exact, but it does appear that there's a higher risk among adults who are immunocompromised. And when you start adding additional comorbidities, whether it's diabetes, high blood pressure, advanced age, these types of things tend to build up. And so that's what we know in terms of the impact of COVID-19. In our province, fortunately, there have not been a large number of transplant recipients that have been impacted, but we have seen complications that do align with those numbers to some extent. The other thing that's, I think, from a big picture perspective, important to remember, and I'm thinking about this in terms of schools reopening and all these kinds of issues, and as we've seen already happening in our province in the last few weeks, exposures will continue in the community, and that includes schools. It's not so much a matter of if these exposures happen; it's a matter of when. And so, the policies that public health and the governments have put in place are very robust, but they're meant to really minimize the impact of these exposures and reduce the spread as much as possible. And they've put a lot of thought clearly into trying to develop those types of mechanisms. But that is the reality, is that unfortunately some exposures will persist. Next slide, please. So how do you protect yourself? And I add the public here as well, because that is obviously an important consideration also, to protect each other. So as has been alluded to already by Dr. Blight-Hansen and Dr. Michevich, that basically public health guidelines are out there. Physical distancing or social distancing really is the big piece. Masks are helpful in environments where physical distancing is not possible. As Tom mentioned, it is important to remember, and this is important when you're considering schools and what you're doing with your kids potentially, that masks don't really protect the mask wearer to a great extent. It's better than nothing, but it doesn't really, it's not a huge benefit from that perspective. But universal mask use in certain environments, as is being done in transit, for example, can be quite effective at the mask wearer from spreading any germs, and therefore protects everyone in that environment. So that is something that is useful. But importantly, the wearing of masks should not replace physical distancing whenever possible. So that's still the key, is maintaining your distance, and also base measures like hand washing, not touching your face, all those kinds of things. The other kind of general protective things, and for those of you that may have seen Dr. Henry's media announcement this afternoon, obviously there's a renewal of making sure that, as in general, we're limiting social circles, we're avoiding large gatherings, really clamp down on those groups, and that's going to be critical in terms of what happens with the school reopening in order to sustain that. And then the other thing I think to remember for transplant recipients is that you may not present in a classic manner. So fever is the most common symptom. You may have difficulty breathing, cough. That's classic cold flu-like symptoms. But not everybody presents that way. About 15 to 20% of transplant patients can present with diarrhea. There can be different presentations that aren't classic to what you may have heard on the news, and therefore you have to have a low threshold to consider the possibility that COVID could be in the mix if you've had an exposure. And then in terms of what your individual risk is to you and your family, it really varies on your disease state, as well as to what degree you're interacting, and those decisions that many of you have already made right now in terms of how you've conducted yourself have taken into account the risk benefit of what your individual risk is, and what the risks are of not interacting with people, what the benefits are of interacting with people. And that's kind of the process that unfortunately we have to continue to really look at as we move forward. Next slide, please. And so kind of the question, should you send your child back to school if you're an immunosuppressed individual? I think we have to continue that same process where really it's an individual risk benefit. As I've said, there is an increased risk of complications among transplant candidate recipients. Certainly having a family member in a school environment will increase the risk of being exposed, but I can't tell you to what extent. We don't simply have the data to quantify that. There's not really any great data that's going to really be directly applicable to us. Certainly there's other countries that have done things that are in similar situations to us, but in terms of actual numbers, we don't. But I think there is certainly an increased risk. So how do you navigate that? Well, I think first you have to kind of discuss your individual risk with your transplant team. We cannot generalize and say everyone who's a transplant recipient is the same. There's different comorbidities, there's different levels of immunosuppression that are at play. So you need to talk to your team to figure out where your risk stands in general. And then the other thing that I'd encourage you to do is to understand the policies that are in place at your individual schools, right? There's lots of variability out there. There's some great requirements that are there and some standard guidelines, but different schools, different school districts are handling it a bit differently. And so questions you may want to know are, what are the size of the cohorts or the learning groups? What are mask policies within the school? What are the requirements for health check by parents before they send their children to school? How rigorous is that? What's that involved? And then you have to discuss your individual circumstance with the school to understand what options are available. And I think those are evolving, but certainly it has to be an individualized case. And then it really boils down to weighing the pros and cons. You know, we know, like everything in this pandemic, it's been a matter of understanding your risks as best as you can, understanding the what you can do to protect yourself, and then trying to figure out how do you live your life and do the important things like go to work, send your kids to school, and what are the pros and cons of the different options that are available to you. So that's kind of, I think, the approach that we've taken. Certainly as transplant programs, we have resources to support you should you need documentation to confirm your medical risks, to confirm what that is. But ultimately, it really does boil down to an individualized risk-benefit scenario. I think that's all I had actually for now.
Great, thanks so much, everyone. And that leads us to our question and answer portion of today's webinar. A sincere thank you to everybody who submitted questions. We received many questions, which is great, as it shows the level of interest in today's topic. Just to note that you may not hear your specific question asked and answered, nor are we able to offer any specific medical advice for any health issues. And in order to try to address as many questions as possible, we have reviewed all the questions that have been submitted, and we will answer those of a similar nature collectively. So we do thank you in advance if you don't hear your specific question asked. We are also very fortunate to have a special guest with us. We have Kat Broad, who is the social worker with the Multi-Organ Transplant Program at BC Children's Hospital. And she has joined us for the Q&A to help answer any questions around coping or mental health that any of you may have. So without any further ado, we will get started on our Q&A. Now, we do have some pre-selected questions that have come from all of you that we will help get started. But please, just a reminder, I do see some of the questions are trickling in, but now is a chance to open up your little toolbar and start typing in your question and answers. And don't forget to also vote up other questions that you do want to be asked. So the first question we actually have is perhaps best suited for Kat, but again, to all our panelists, just a reminder that if you do have something that you would like to add, of course, please speak up at any time. So this one is, so for families unable to establish a social bubble and who continue to practice strict protective isolation, do you have any recommendations for how they may address their child's social and emotional well-being while continuing to support a healthy growth and development? So this is for children who have either limited or no exposure to other children right now.
Yeah, thanks, Christy, and thanks for having me and for everyone that's called in. I appreciate this question because it comes up a lot in my clinical work in supporting families. So I apologize to those that are calling in and have heard me kind of give similar responses before. But ultimately, the first step in any of this is, like Dr. Gill said, is consulting with your physicians, first of all, to see what they think is safe in terms of expanding your bubble for your specific family and children. And if they feel like it is safe for you to have some contact, I think it's important to acknowledge that we've been in a state of avoidance for a really long time. And when we're in that state and we're feeling anxious, we're driven to avoid more. And so it can be really hard to then test those waters to say, when are we feeling a little bit more comfortable? What I've been suggesting for a number of the patients that I work with is to start with really small steps. So we know that most kids do really well when they have some structure and routine, as well as when they have opportunities to socialize. Now, a lot of the kids I'm speaking to are pretty sick of connecting on Zoom and FaceTime, I'm going to be honest, but that's certainly one way in which people are staying connected, which you all know about. But I certainly have been talking with families about testing those waters with socially distanced catch-ups or play dates that are safe, again, that your physician has said is okay, but trying to find ways in which you can give them the opportunities to connect socially, but without kind of too much risk, and remembering that just like when kind of in the early days of March, everything felt very fearful and anxiety provoking. And over time, we've gotten used to a lot of the world in which we're living and where these restrictions still exist. And so the more that we kind of test those waters in a safe way and expand, and gradually increase kind of our ability to provide connections for our kids, then the more comfortable it will be over time. And we've seen that in kids that have started with very small one-to-one play dates with families that they feel safe and comfortable with that are following similar restrictions. So I encourage you to have the conversation with your physician first and foremost, make an informed choice around what you think is going to be safe, and then be confident in that decision and try and see that through, knowing that it will feel anxious and weird at first, but it is something that we want you to build upon going forward.
Great, thanks, Kat. And Kat, just to follow up on that, we have a question regarding resources in the community. So are you aware of any community resources that exist that can help support children through COVID, as well as the return to back to school? Or any of you, of course.
Yeah. So there's a number of resources that are coming out. The best ones that I recommend, and I can certainly share them in the chat as well and after this presentation, are the ones being provided by Kelty Mental Health, which is done in partnership with BC Children's. They actually did a really good presentation last week, I believe, that was about return to school specifically, and I can share those slides, but it does speak to not only how to kind of approach this weird and unprecedented time that we're in as parents, but also it provides a list of resources as well within that around where to go to when you need extra support, not just through your team, but also outside and in the community.
Great, thanks, Kat. And a question actually that's come to us live, as well as one that was pre-submitted. So obviously that shows a great deal of interest in this one. Is around for transplant recipients who are adults, who either are teachers or work in the educational system, or perhaps have other jobs who require them to engage on a regular basis with the public. Is it safe for them to return to work? How risky is it? Do you have any other, advice or suggestions? And perhaps we will pose that one to Jag, but of course, open to anyone else who wants to add additional feedback.
Sure, I can start. Yeah, I mean, that's a question I get every day in terms of what the right thing to do is. And it really, unfortunately, I'm going to sound like a bit of a broken record in that there isn't a blanket recommendation. There isn't, kind of a blanket statement other than we need to kind of take it case by case, right? So if you look at somebody who's in a high risk environment, the priority needs to be, how can we make that environment as safe as possible, right? Absolutely, there's a higher risk. If you're immunosuppressed compared to me, who's not immunosuppressed, you're going to have an increased risk as an adult of developing COVID and of having complications related to it. As I said when I showed the slides, I can't quantify that fantastically well based on the data we have, and we'll have more information after the fact, but it is a higher risk. And so our advice is to exercise the maximal amount of caution that is reasonable. Now, how do I define reasonable? Well, it kind of depends on your individual circumstance. If I think it's worthwhile to advocate to your employer to make sure that all the protections that can be put in place are put in place. And if there's considerations that can be made for you, given your situation, we're happy to support that. And that's the kind of stuff we've been doing in our program, which we've kind of just been giving letters of support saying, if PPE is available and required, that should be provided. And if there's a remote option for this individual to work and maintain their livelihood, that should be provided. And so I think really, the message here, for employers, for all of us really is we need to understand we need to have a lot of flexibility in terms of how we do things now, as we all have become accustomed to. And so that's kind of that's probably the way to go. I can't simply just say, well, don't go back to work, because that may not work for you, right? Some people may be able to pull that off and other people might not be able to pull that off. And so I don't think it's reasonable to have a blanket, you shouldn't work or you should work. It really needs to be each individual circumstance to weigh those risks. And as I said, you need to probably talk to your individual physician and say, what are my risks? And do I have a base risk? Do I have additional risk factors that can help inform that decision?
Great, thank you. I don't know if anyone else has anything they want to add. I think Jag was pretty, he provided a lot of information on that one.
I might just add something, Christy, to the previous question, which is kind of related, and that is that when we have our discussions with parents about their children who are transplanted, a lot of the discussion is around trying to frame risk and what does risk mean for the child, in general, we're speaking about children that we wouldn't consider at high risk, and then how does that family frame risk for themselves? And I've been asked many times, should I do this, or is it okay to do that? And really, my risk threshold is going to be different from somebody else's risk threshold. The reason these questions are being asked is because we don't have 100% complete information to be able to adjudicate each of these types of scenarios. And so we end up having to make the best decisions for ourselves. And, as it relates, for example, to, should my child play with, the child across the street? Some of these things have to do with trust and understanding what is the circumstance that you're putting your child into. Do you trust that the parents of that child and the environment around that child is taking the risk seriously, and that they're going to be doing the necessary cleaning and physical distancing and mask wearing, et cetera, that you would have your own child do? And so it's an appreciation, though, that this is all very anxiety-provoking for people to be in a situation where you don't have all the answers and you're making what can seem like life-or-death decisions for your family about things as seemingly banal as, should I send my child back to school? The transplant programs are there to support you in that decision-making. We can give you the best advice that we have on the day. I'm quite sure that the advice that we're going to give is going to look a little bit different 6 months from now than it did today, and I know that it looks different from what we were thinking 6 months ago. But as we learn, we can give better and better advice and hopefully fine-tune that information so that at least you have the backing of an informed decision, but then to support you in trying to make the decisions that are going to be the best for you and your family and your child, if that's the case.
Great, thanks so much. We also received a great deal of questions related to grandparents. So a question for grandparents. So for grandparents with grandchildren of preschool or school age, do their interactions need to potentially change once they return to school, preschool, or daycare? So for instance, will grandparents still be able to hug their grandchildren? Will they still be able to look after them after school? Again, I know it's a tough one. It takes a lot of things into consideration. But do you have any further, perhaps, Tom or Jeg or anyone that you would like to add to that one?
I'm wondering actually if Hannah can speak to that.
And Hannah, sorry, of course, Hannah.
I'm sorry, can you just repeat the question one more time?
Yes. So for grandparents with grandchildren of school age or preschool age, do their interactions need to change once they return to school or daycare? For instance, can they still hug them? Can they still look after them?
That's, again, it's a tough question, isn't it? Because it will depend on each family's individual circumstances. So, anytime we expand our circles, and schools do mean expanding a circle, the chance of child coming back home with COVID or another infection, for that matter, will be somewhat higher. So it becomes a bit of an individual judgment call, but a lot of it for me goes back to doing proper hand hygiene, making sure that children and grandparents are on top of immunizations, making sure that you are not in contact if the child becomes symptomatic, and then the onus is also on the schools a bit to inform the families immediately if there is a suspected outbreak, so that other household contacts can be involved as well. So I won't tell you not to hug your grandchild or not be in contact with them, but it does become a risk. Depends on what your risk threshold is.
Okay, great. I don't know if there's anyone else have anything they want to add to that. Okay, great. Thanks so much, Hannah. We will go to one of our live questions. So in the regular population, the age of 10 and up seems to be the difference between pediatric and adult transmission and infection. So is that true of pediatric transplant recipients as well? And if it, if it is, if the adult transplant, we'll first answer that one.
Sure, I can start, and Tom, feel free to add. So with a small number of pediatric cases of COVID that we've seen in BC and in Canada, below the age of 19, there were definitely more in the age of 10 to 19. So I think the older children become, the more they start looking like adults. In general, the number of cases below the age of 19 were still much lower compared to the older age groups, but there's definitely a bit of that transition period. Kind of the older you are, the more similar to adults your risk factors are considered to be.
Okay. And so for adult transplant recipients, oh, sorry, did someone else want to add something?
No, I was just going to say that one thing that we don't know as well is, I think one of the questions was around the transmission of the virus of infected patients, and if, I think the understanding is that the younger the child is, the less likely they are to transmit. That may not be true for immunocompromised populations who may have who from other viral infections can have a more prolonged shedding. So it is important to keep that in mind also.
Okay, great. Thank you. And you perhaps slightly answered that one already, but in regards to adult transplant recipients, so what age does that risk start to increase? Is that really hard to kind of quantify?
It's hard. I mean, I think, as I said, so much of the data is preliminary right now. And, and the one thing that is reassuring is that we're looking at relative risk, but the absolute number of transplant patients that have been infected is actually thankfully not been very large. Right. So when we're looking at the series that are reported, people are reporting on case of 20 to 30 individuals within. Someone had asked them the questions what the age range was in some of the studies that I was referring to. And so that age range has been anywhere from people, in their 20s up to 70s with an average or median age of around 50 to 60 years old, typically, as the transplant recipient populations that people have reported on. So we don't have enough of a detailed understanding to know at what age point does it really flip. I mean, I think it's probably a safe assumption that when every decade you get older, your risk is going to be a little bit higher. So if we glean from the general population, what we've seen is, 40 to 50's got a slightly higher risk, 50 to 60, and then 60, 70 on. And every kind of decade you go up, you start to see a slightly increase with kind of a big spike up when you hit people in their 70s and 80s. And so I presume that's also the case for transplant recipients, where we're seeing that. Whether that's purely a function of age or other medical conditions that present in addition to the baseline issues that they've got, we're not sure. But certainly, I think you see a trend with older age. I don't know that we're seeing that exactly at the age of 20 or 30. I think we just simply don't have the data to say that yet.
Okay, thank you. And we had a question, a pre-selected one, regarding cleaning measures for children and items after school. So what cleaning measures would you recommend that would be necessary for both children and school items such as backpacks, lunch boxes? And I'm not sure who would perhaps best be the one to answer that. Maybe Hannah, you would like to take a stab at it, or anyone else on the panel?
Sure, I can start, and feel free to add. And I can just imagine how in your busy lives, like the extra task of trying to wipe down everything that was touched when you came back from schools. So still, again, priority washing hands very frequently with soap and water for 20 seconds, not just running in and out of the bathroom saying hands are clean, because children use hands to touch their faces, and they use hands when they go to the bathroom, and COVID can be shed in the stool as well. So if you were to pick one thing, focus on cleaning hands. How much is COVID transmitted through surfaces not being wiped? To some extent, although definitely way less than by hands and things that have been in contact with our nasal secretions. So, keeping things clean helps. Do you need to virus wipe every lunchbox and everything that was held on a daily basis? Probably not as important.
Okay, great. I don't know if anyone has anything further they'd like to add, or I think that one was pretty sufficiently answered. Excellent. All right, so we have a question. I know it is a little bit similar to some of the past ones that have been asked, but perhaps there's something else the panel would like to add to this. So we have a lung transplant recipient who has 3 kids. For people who have children that perhaps are not the best at understanding the risks, because as we know, especially younger children may have a challenge with that. So in those situations, and if they're all going back to school and you can't be with them all the time, you can't be reminding them, what are some potential ways that they can continue to be safe even despite that risk, even if they still go back to school and they're not perhaps practicing all those, the hand hygiene, the masking? Is there anything that we could perhaps add?
I can take a stab at that. I mean, I think there's no magic bullet, right? This really, when it comes to battling this issue, it really does boil down to do the best you possibly can with the measures that have been outlined. So, I think absolutely it's a given. A young child is not going to be able to adhere 100% to all of these things, but if they're doing that to their best ability, and if schools have enough measures in place, and I think a lot of schools will have measures and do have measures in place, which is going to really be promoting hand hygiene, promoting some distancing, promoting, monitored playtime and these kinds of things. So, time will tell how effective that is, but it sounds like, looking at the plans that are out there, that there certainly will be mechanisms in place at many schools, and hopefully all schools, to really reinforce these behaviors, right? And I think, just speaking from personal experience, sometimes focusing on the 2 or 3 things that we know work best is better than trying to think about a laundry list of 15 things that you could do, particularly when we're dealing with children. To just kind of say, wash your hands, maintain distance, and kind of that's it, and focus on your learning to some extent, would probably be the messaging that as a parent I would think of. But if they're not able to do that, some of the issues in terms of, coming home, washing your hands really well once they are home. I think also being very vigilant for early signs. If you're particularly concerned about your child, you talk to the teacher. I think being proactive with those kinds of measures. I know teachers are very busy and inundated with things right now, but I think everybody wants this to go well, and so I'm assuming most teachers would welcome any concerns that you had, or any feedback that you had in terms of saying, for my child, can you watch out for this, or can we help? How can I help? And that's probably there's no easy fix, but that's probably the best way I'd approach it.
Okay, great. And I'm not seeing anyone else unmute themselves, so I'll assume no one else has anything they want to add. So that gives rise to an important point around anxiety. COVID is going to be on the mind of everybody, especially with the return to school. So Kat, I have a question for you. Do you have any tips or suggestions around how to cope with this ongoing and perhaps mounting stress and anxiety that our children may experience, as well as our parents may experience, with this new return to school?
Yeah, thanks, Christy. Again, a really common concern is how to support our kids during this time, and particularly around return to school. I'm going to go back to the fact that I think everyone is experiencing stress right now because of the pandemic, but to say that parent fear, just like children's fears, they kind of are in a circular kind of way. So when a child feels scared and fearful, they're going to look to the parent. If the parent feels fearful and scared, that's going to impact their children as well. And I think you all know that. But it's to be really careful around the messaging that we're giving our kids at the moment, that if we are making decisions that we're saying we still feel a bit uneasy about, and I would say that almost all decisions you're making right now, you would feel a slight degree of unease because we can't give you certainty, to kind of remember that, be confident in your decision and be saying to your kids, the reasons why you're confident, rather than constantly saying wash your hands, be careful. Like, they need to hear messages like we believe that the schools and your doctors are making really good advice and they think that you're safe to go back to school. And so to be confident, like changing that message around fear and trying to bring it back to confidence, is really important to help also manage your own anxiety. And I think the key things is to take each day and week as it comes, to not get too ahead of yourself in terms of what are we going to do if, because as you've known already, where our flexibility muscles are being tested all the time. and it's really hard to predict entirely where things are going, but we can make decisions in the moment now and be confident in them. And I think also to set some limits around like hearing of the news and how much you participate even in webinars like this, that, you know, just like your kids are being exposed to information, we want to limit that to a healthy kind of level, the things that you and them can cope with, and to give them information, your children information around, you know, what's going on in an age appropriate way. So simplifying things down into a way that they can understand that's appropriate for their age and also whatever else that's going on. I know that there's been a lot of questions around individual circumstances and, you know, individual children's needs. And I would always, like, I know that Dr. Blynn Hanson and I have had a number of conversations about families making like their best judgment and, you know, assessing their own family and their own child, and not just getting information from us, but also looking at your child and what your child's needs are, and backing yourself as a parent or a caregiver and saying, you know what, this is, I know my child best, and this is what's going to help them out. And I think that that's all you can do. But as I said, I will continue to share some resources in the chat that have been shared already around how to support not only your children, but also yourselves as caregivers and parents.
Great, thanks, Kat. We also had another one come in regarding, are you aware of any a resource or community connection around accessing other immunosuppressed children that potentially, you know, transplant recipients could play with? Obviously they're not feeling comfortable expanding out in their bubble. Do you know of any type of resource like that?
I don't, but that's certainly something that has been discussed. We are running, and within the BC children's population, we're running caregiver and parent groups, but we haven't actually expanded to children yet. There's talk of us working on a youth and adolescent group, but it'll be virtually and via Zoom. So it doesn't necessarily meet, as I said, the entire need for social connection, but we're certainly in the stage of the pandemic looking into other ways in which we can provide opportunities for peer and peer-to-peer or self-connection support. So yeah, definitely on the cards, but keep any feedback and ideas coming.
Great, all right, thank you. Just being mindful that we are running out of time. One question that was voted at the top, we will only ask maybe one or two more questions, then wrap up. So compared to last year, you know, a lot of recipients struggle every year with various viruses that are circulating. So is there really a big difference between this year and last year when all of those viruses and other factors can be taken into account that pose some serious consequences? And I'll put that out there to anyone who wants to ask that or answer that one.
Well, I might just start by, I know Dr. Mitrovic already mentioned this, but, you know, we would still recommend getting the flu shot, for example, in the fall. But we, you know, for children, and I know it's the same for adults who are transplanted, the recommendations we make all the time, every day about hand washing and hygiene, independent of the pandemic, are really the things that we need to do to try to stay safe and healthy in the world. You know, when we go ahead with transplantation, the purpose has always been to help people live their lives with a transplant, not to shut them in a bubble wrap. And so really the message is, with this new wrinkle that we're dealing with, how do we continue to try to live our lives with a transplant, but at the same time take the necessary precautions so that we don't put ourselves in jeopardy. And so of course it's a balance. But the things that we normally teach or talk about with our families in terms of staying healthy and avoiding infection are really the things that we would continue to recommend going forward, in addition to the additional measures we're taking with COVID.
Yeah, I agree with everything Tom just said. I just, you know, I think add to that the only big difference between this year and previous years is there's more question marks. So, you know, in previous years, when you're dealing with viruses and bacteria and other infections that we've had years of experience with, we generally tend to have a better sense of what to expect, how to pick it up, what to do, and just, you know, and you don't necessarily have a population as a whole that's as susceptible, right? You're not going to have, there's no public health consequence, there's no, to the same extent, and so the anxiety that I think most people are experiencing now is because of the unknowns, and that's what makes it different this year. If COVID-19 is still around 2 years from now, my prediction is our handling of it will be dramatically different than it is right now. As we develop more information, have more treatments, have a better understanding of where this virus is going, vaccine or no vaccine, I think we'll be in a better place as we move forward. But that's my take on it, not as an infectious disease specialist, but as a transplant physician.
All right, great. Thank you, everyone. I noticed the time. I know that we are right on 5:30. So unfortunately, we still had a lot of really excellent questions, and I apologize that we weren't able to cover more. But I will hand it back now to Tina, who will wrap it up for us.
Thanks so much, Christy, and thanks to all of the panelists who made time today to present and answer everyone's questions. Like Christy said, I'm sorry that we weren't able to get to all of the questions. When the webinar's ended, your computer should open to a new page asking you to complete a webinar survey. So please take a few minutes to fill that out if you can, and there'll be an email probably in the next couple of days that will remind you. That really helps us if you fill that survey out to let us plan future potential webinars on COVID or on other topics. And as I said, this has been recorded, so it will be made available on our YouTube page in the next couple of days, and we'll send the link out to all participants as well in one of those follow-up emails. So again, thanks so much for joining us today, and really appreciate you taking your time to spend with us, and we hope you all stay well and enjoy the rest of your day. Thank you.